Celine and Jeff, and together we are LymphaTech. We're improving the lives of breast cancer survivors. Imagine someone you love, mother, daughter, wife, or sister, has just survived breast cancer. And now imagine that her arm has permanently and painfully swollen up to 8 times its normal size. This is a debilitating condition. It's known as lymphedema, and it reflects an inability of the lymph vessels to return fluid to the body due to the damage those vessels sustained through chemotherapy, radiation, and surgery associated with breast cancer treatment. There are 2.7 million breast cancer survivors in the US today, and 250,000 more each year. And as we get better at treating breast cancer, we need to start focusing on the survivorship issues that come up in life after cancer. Lymphedema is actually one of the most prevalent because half of all of breast cancer survivors will develop this disease, and it can occur at any point for the rest of their lives. Our team has each been personally touched by a woman that has developed this disease as long as 20 years after her breast cancer treatment. So clearly, this is an ongoing issue for these women. This shows a typical disease progression for these patients. You can see the left arm of the woman as it grows from 0% swelling up through a gross amount. So the percent swelling there is indicative of how much the woman's volume has changed. In the earliest stages, before 10%, the swelling is actually reversible, and we can return the woman to a normal state of life with the use of compression therapy, massage techniques, and constantly worn compression sleeves that cost approximately $1,000 and takes a period of about a month. However, if the disease isn't caught before 10%, the woman's left with this swelling for life, and she has to continue to undergo these procedures, same procedures, just to make sure she doesn't undergo further swelling. The big problem here is the gold standard of diagnosis is literally a tape measure, and it can't catch the disease until the woman has already swollen by 20%. That means, yes sir.
So why doesn't everyone that's gone through this procedure just go through the process of that compression just as a preventative?
Thank you. That was one of the first questions we asked during our customer discovery. Would you be willing to undergo that? And the breast cancer survivors unanimously said no, because one...
Yes, 100%. Said no.
Yes.
How many people did you ask?
We talked with several, but the point here...
3 or 8 or 11?
I can't recall exactly how many, sir. The point here is that not only are they unwilling to continue the sleeves and the compression, it's not actually effective until the disease has already begun. So if you wear it for 5 years and you never would get the disease, you may stop wearing it and get the disease the next day, and the sleeves would have done you no good, and yet would have still cost you all that money.
Okay. What is the treatment then?
The treatment is the compression therapy, the compression sleeves.
Before, what do you do?
Yes, if you catch it before 10%, you begin applying that treatment, and that actually causes the lymphatic vessels to restructure and promote the additional flow necessary to keep you from getting the swelling. So, an early stage diagnostic.
So that would mean again that if you were able to apply the therapy prior to, if after you have breast cancer, and you can, apply periodically or whatever else, that's not, effective.
I'm going to turn this over to Mike. He's the PhD on the project.
So there's actually a very narrow window where this therapy is effective. If you do it too soon, it doesn't actually help you, and if you do it too late, it's too late. So you have to wait until the disease starts, and then you have from 0% to 10% where it's effective. But you can't do it as a preventative. You have to wait until the disease begins before the therapy is actually helpful.
So 0.1, and you're saying at 0 it doesn't work.
Right.
But somewhere.
So there's a disease cascade that starts the progression, and you have to wait for that incident to occur.
What can happen during the early stage that is precluded once the disease is beyond a certain point?
Yeah, so you actually have permanent tissue remodeling. So you get fibrosis, you actually get scar tissue, fat deposition, and once you do that, there's really no way to get it out of the arm. There are surgical techniques in very extreme cases, but you can never get it back down to normal. So it's really just a tissue composition permanent change.
The key here is that an early stage diagnostic would allow the doctors to begin that therapy early enough to put these women back to normal. In fact, that's what the National Lymphedema Network noted, that an early stage diagnostic is the most critically needed advance in lymphedema care today. So we've had conversations, as I said, with breast cancer survivors, with their doctors and with hospital administrators. we've identified the 3 key functions that this diagnostic needs to have. First, it needs to be able to track lymphedema progression. Second, it needs to be able to provide an early diagnosis, enabling that treatment at the earliest stages. And finally, it needs to be available for use in the patient's home so that she can monitor herself regularly and actually catch the disease at the earliest stages. There is a range of current technologies available, including the tape measure, all the way through the PET scan. But even the PET scan is really just a more expensive tape measure here, because it's only going to show how swollen the woman's arm is currently. So it's ineffective at catching the disease in the earliest stages. We've developed a revolutionary diagnostic that can actually perform all 3 of these functions, specifically catching it before the 10% swelling mark.
The PET scan would use a contrast dye, and it would be something that you would be able to look at volume, pressure, things like that, right?
But again, all you're measuring is the change in tissue composition. But by that point, you've already had the changes. So it's really too late already.
But again, you said that you have to have change.
You have, so this is actually where our technology comes in. So we're going to be looking at the underlying lymphatic function. So you actually have a deterioration in the flow of your vessels before you get the symptoms. So all of the current diagnostics in the market today look at the symptoms, but they don't look at the cause. And that's really the key here, our big competitive advantage.
And the disease progression occurs over roughly a 12-month span, so you would need to be getting these scans roughly every month to catch it in the earliest stages. Otherwise, I mean, you can imagine going through a PET scan every month would be prohibitively expensive.
These dyes that you have, then they're FDA approved dyes. I mean, how often are you need to inject them, and have they been approved for that frequency?
Good, sure. So great question. So they're approved right now for cardiovascular uses, so very similar to lymphatic vasculature uses. But we'll talk about in our regulatory strategy, that's actually the key thing that we're going to need to get approval for is lymphatic use and then the frequency that we want to do for our scans. Yeah, excellent question.
So this device is going to provide value to these 3 groups: patients, providers, and payers. The patients are looking for an improved quality of life. We're going to help them reduce their worry about this long-term disease and empower them to take charge of their own care. The doctors are looking to improve the standard of care, but also be reimbursed for their time. Right now, the tape measure procedure is lumped in with the rest of a doctor's visit, whereas our device has a separate code which is reimbursable, allowing a doctor to perform it and obtain reimbursement for that. In addition, there's a new American Cancer Society recommendation that all patients be regularly screened for lymphedema. And right now, there's no device that's really effective for that. That's really pushing our market here. And finally, the payers are looking to improve patient outcomes, but at the same time, they have to manage their bottom line. Costs are out of control with the way the tape measure is failing to catch the disease. We're going to provide them a way to bring those costs down. In fact, a recent study in the Journal of Physical Therapy shows that a device exactly like ours in the lymphedema space would provide a 60% reduction in costs yearly. That's a $2.5 billion savings. That's going to completely change the way we spend money on lymphedema in America today. That new market is going to look like this. There will be $1.7 billion in annual spending in the US, of which $850 million will be spent on the diagnosis. $425 million will be spent on the actual device and ancillary services, and this is the market that we've defined for ourselves.
So how do we actually bring this value? We sort of alluded to it here. All of the current technologies look at swelling. They look at the status of the arm. But we're looking at the underlying lymphatic function, and we do that with a powerfully simple lymphatic pressure measurement technique. Think of a blood pressure measurement for your lymphatic system. Blood pressure revolutionized the way we understand and treat cardiovascular diseases. We think this has the same potential to transform the standard of care of lymphedema. So, how does it actually work? Blood pressure is measured acoustically, but that really doesn't work for lymphatics, so we do it visually. And it begins with the injection of an already FDA-approved near-infrared contrast dye. And so that's in the injectables that you see there. We give the injection with a microneedle. So it's a very small needle at the tip. It's exactly optimized for lymphatic delivery into the skin, easy enough for a patient to use on their own at home. So once you give the injection, the lymphatic vessels naturally take up this dye, and then we add the pressure cuff on top of the patient's arm. But it's a much more robust pressure cuff, and this is a nice prototype here. We have a series of optics and sensors built into the cuff that can detect the presence or absence of the dye flowing through the vessels beneath the skin. So then after that, it's very similar to the operation of the blood pressure cuff. We increase the pressure in the cuff. As the pressure increases, the vessels eventually close, the fluorescence is cleared out, and then we gradually deflate the pressure in the cuff. Eventually the pressure gets low enough that the fluorescence is restored, and that's lymphatic pressure. Very simple, quantitative way to assess the underlying physiology, get a sense of the very early stage disease onset before you actually have swelling. We will then prescribe the therapy at that exact moment. 1 month, very simple, and you don't ever get the swelling.
So,
Yeah, please.
So when this disease,
Mhm.
its propensity, if you look at the life cycle curve of it, would most of it occur, I think I heard you say 12 months after surgery?
The biggest risk profile is 0 to 5 years.
0 to 5 years.
Mhm.
Okay, and is that even across the board, or is it most the first year, or is
Yeah.
it just a normal curve, or is it straight across?
Pretty straight across. There's a little bit of a curve to it. It actually peaks right around 2 years, interestingly. We really don't know why that is. But then you have a plateau where it kind of maintains a lower risk profile, but a steady risk profile, all the way out to about 20 years post-surgery. So our big target is that 0 to 5 year window, actually. That's an excellent question. And so the nice thing about this metric, not only is it really accurate, it's 9 times faster than the tape measure. Tape measure, they have to measure every 4 centimeters. It takes about 45 minutes. Ours is 5 minutes or less. That's what doctors have told us they want. If they want a new diagnostic like this, it has to be fast. So we specifically engineered it to do exactly that. So let's talk about the current status of the technology. This is actually my PhD thesis research. I love talking about this. We have a very functional prototype in the lab. I've been working on this personally for about 4 years. We have proven success in animal models. We have a lymphedema model in the lab. We've done an extensive amount of testing on it. We've shown in these models that it works exceedingly well. We've done first-in-man feasibility studies. So just to orient you here, the image on the left is actually what your lymphatic vessels look like with this contrast dye. So that's what the cuff is seeing beneath the skin, if you will. So we've demonstrated that this does work in humans, and we're very well positioned to move right into the next step of human clinical trials. The technology itself is also very protectable and protected. We've filed 2 provisional patents. Robert Jones here is actually a registered patent agent, so that's a nice asset for our team. We're working, obviously, to file the utility patents. One of the big challenges for our company is that Georgia Tech owns the rights to this technology. But fortunately, the university is very keen to extend exclusive licenses, especially when the business is from the university itself. So we already have a term sheet with them. We're looking at about a 1% royalty fee agreement. We know that this is kind of the big key for us moving forward because we don't have anything without that license. Yeah.
Is there an upfront fee? Is there equity? Is there?
So they would like to recover their fees for the patent filing. They have a lot of different ways they can negotiate it, but usually if you take the 1% fee, at least on the one we've seen, no equity involved in that.
And who pays for that prosecution?
Yeah, so if we take on the rights, that would be our burden. Yep. And so then the other nice thing, so we have a lot of algorithms built into actually how we generate these metrics, and we can keep those as a trade secret to give us protection moving forward. So let's look at the business model. How do we actually take this technology and generate revenue from it? We have 2 sources of non-recurring revenue. This is actually sale of the diagnostic itself for about $500 wholesale and an accompanying optional warranty package. We sell this to 2 main customer groups, doctors for use in the clinic and patients for use at home. Now, both of these groups use the device in the same way, and this represents a recurring source of revenue. Every time they do the scans, we give them a preloaded injection kit, similar to what you've seen right there. So we would do this as a subscription model. We would send it to them every month just to help them do the scans repeatedly. And then when they perform the scan, the device actually sends the data to our servers. So this allows us to keep our algorithms separate. We can also collect the data and get smarter and smarter with our algorithms over time. After we analyze the data, we send the scores back to the device, as well as automatically update the patient's electronic health records. So this keeps a nice track of the patient's progression, helping us to identify the disease onset in its earliest stages, and helping to facilitate the interaction between the doctor and the patient, really empowering the patient. Yes?
How do you transmit the data?
Yep, so we're going to partner with a healthcare IT company that does this. There's several options that we're exploring as far as the data transmission, whether it's Wi-Fi enabled, do they plug into their computer, is there an online portal? So we're really going to defer to their expertise on that and have them make some recommendations to us as far as what's the most feasible option.
What are the other vital signs that are taken?
Yeah,
Or
so,
required to be taken?
right. So we're right now just focusing, minimum viable products is mainly just this pressure measurement technique. There's a lot of built-in functionality that we can get a lot of other metrics, lymphatic flow, lymphatic contraction rates, a lot of which I won't bore you with, but there's a lot of growth potential here that once this is the new standard of care, we can really get very robust profiles. And this has a lot of future potential applications for other diseases as well. The community is really excited about the growth potential in the next coming decade or so.
Using that as a platform to look into other areas of assistance and
Yeah.
analysis, are you protected in those areas as well?
Yes, so we're working actually to file several other patents, very broad claims, so this is a near-infrared imaging-based technology, and so some of the claims that we're going for are just very general lymphatic analysis with near-infrared, which gives us the ability to do imaging, pressure analysis, individual patient mapping, a lot of different applications. Yeah, so we have that kind of forethought in mind for sure. Yes?
In your business model, what are you assuming? I know you've got $10 for physical time, you've got $5 for the report.
Mhm.
Tell me what the relationship is, these kinds of charges. And is there, in the $5 charge, it seems like if you're in the department, they're going to want a piece of that
Yes.
as well. What are you assuming?
Yeah, great question. So this price model is based partly on the economic analysis that Robert was referring to. And we've also done an extensive amount of customer discovery with clinicians to try to figure out what this price point is. It still is a little bit fluid, but this is the general numbers that we think work well. There is room to boost kind of the margins, especially in the recurring revenue side. People have suggested to us maybe even shift more to a razor blade model. But people really get excited about these prices, and it is sustainable as it is. But we're really looking to generate strong acquisition with this price point. And so that's kind of how we got to it initially.
What sort of assumptions did you make for the conversion rate of people wanting the warranty?
Yeah, so the warranty is mainly for the clinic. We don't really see that the home users would be a strong draw for the warranty, but almost invariably the clinics don't want a one-and-done type sales process. They want to be sure that if they make this purchase, they're going to have a nice relationship going forward. So we offer it more just to kind of generate that sale rather than generate revenue.
So you don't split that out in your financials, right? You just have it all as one line item? You don't have the actual warranty split out in the...
There should be a line item in the income statement for warranty services. It should be the fourth line item.
So that's what that is.
So I don't understand in terms of what do they get for the warranty?
Mhm.
And then what is your standard product warranty?
Yeah, so we're looking at about a 5-year warranty kind of life cycle. Mainly, they don't want to have to service it. If something goes wrong, somebody clicks the wrong button. There's not a whole lot of things that can really, it's not super in-depth, but this is a lot that will go on the IT side as well. But just, somebody that they can call. They don't want to be left on an island. Kind of the broad range, yep.
But again, in terms of coverage, whether it's your clinic or at-home patient, what type of basic warranty, and what's the time frame that they're offering with the purchase price?
So it would be a 5-year warranty, and so if the device broke at any time due to manufacturing defects, that would be covered under the warranty, and we'd replace that device.
But that's, I have to pay $100 for that.
For the warranty piece, yes.
And if I don't pay $100?
Then, yeah, if you don't pay that, then you could send it back and we could identify, if it is because of manufacturing defects, then I guess we'd have a claim to the manufacturer. And so we'd hopefully be able to replace it without that cost.
So that, I can see paying, normally if you're buying electronics or other things, an extended kind of service, warranty. But usually you get at least a year. I mean, so you're telling me that if I take it home, it breaks, I can't, that now I have to send it back or pay to have service?
Right, I guess that's something we haven't thought about. I guess our sales process is still 2 to 2.5 years out, and so that's something when we get closer to that time frame, we'll really drill into those details, but that's a great point.
Oh, the other question relative to warranty is how does that work with your outsourcing your manufacturing? Because you gotta make sure that you have those kinds of terms.
Yeah, so when we enter into the relationship with a contract manufacturer, that's going to be specified in the term sheet. And so we'll have that in the contract that if there are manufacturing defects, that they'll be willing to service the product, repair the product, or replace the product because of.
And is it pretty standard to do a 5-year with contract manufacturers? I'm not familiar with one that does it for that long a period, so.
So we've just had initial discussions with cosmetics and Walgella, and we haven't, I guess, progressed to that stage yet. So that's something we're still figuring out.
Thank you.
I mean, as an FDA regulated product, I mean, you'll have to have, you know, a procedure in place, you know, for, you know, complaints, review, and then resolution. And who's gonna do that?
Yeah.
Your contract manufacturer?
So we actually have built that into, I guess, our sales personnel or our personnel in our company. And so we have, with our research and development team, people who are looking at the technical aspects of the product, and they'll be the ones focused on looking at the warranty plans and responding to customers. And so that is built into our model.
What's the frequency of use?
Yep, so we're looking at about a monthly use. So we would send the patients a kit once a month. That should give you enough frequency, definitely give you enough frequency to detect the disease in the stage that we're looking for, based on our animal models thus far. But that's something we would validate also in our clinical trials. But if we look at our revenue streams, we can see that the majority of our revenue actually comes from our recurring sources, which gives us a very sustainable business model going forward. And overall, we have 64% gross margins, which is very healthy for a business like ours.
Who costed out the bill of materials?
So we actually looked at retail prices, and that's what we based our financial models on. And so if you just buy even one of these diodes or cups, that's how we priced out our cost of goods sold. And so we think if we scale up the business and we have volume discounts, that we'll be even able to reduce our cost of goods sold and increase our gross margin.
So is the cost of goods and, you know, gross margin based on cost of goods that are material or material plus labor, and are they fully burdened?
So the cost of goods sold is fully burdened. So we've broken out all the material costs, and then we've also had discussions, as I mentioned previously, with those contract manufacturers. Typically for a device such as ours, they would actually charge about a 10% net cost plus on the cost of goods sold for manufacturing our device. And so that's included in our financial statements, and so that would be included in this gross margin.
What about your selling costs, distribution costs, that sort of thing? Are you assuming a percentage that will go into that is?
Right. So that is actually something else that we've considered. If you look in the operating expenses, currently we're looking at partnering with PMD Healthcare.
Yeah.
They're actually a company that focuses on home use diagnostics, and based on our discussions with them, they would charge about a 25% commission on each sale, and so that is also included in our.
Great, thank you.
So that's not, your salaries are just your salaries,
Right, that is correct.
So you're all going to make about 100 grand right out the gate.
So those salaries in the first couple of years also includes additional employees that, because we're going through FDA trials, so there'll be contract researchers, and so those salaries are included there. And so it's not just our salaries.
One more budget question, and that's the cloud, the hosting expenses. Those seem really low. Did you get a good deal with someone? Or?
So this is actually based on a study that somebody did looking at a private cloud for a medical device. And so we based that pricing on that study.
So it's only $12,000 for over $10 million of business. That's a big deal.
So right, so those would just be, so those would be costs for maintenance afterwards. So the actual implementation would be much higher, and then the maintenance is what he priced in his study.
Okay, so where are those expenses?
That's so the maintenance cost is $10,000.
Right, and then the rest of the costs are?
The implementation, so in every 5 years, what we've done is you'll see there's an uptick in the hosting expenses, and so that's where the implementation costs, and we feel every 5 years, because there's gonna be new technologies coming out, if we wanna implement a new technology, we'll have that implementation cost again, or if we wanna revisit it. So there is increases.
So you make that initial $65,000 payment.
Right.
And that's only based roughly $10,000
Right,
for
yeah.
5 years.
And that's what, is studied.
I understand that there are clinical trials that are being undertaken at the moment, and what's funding that?
We've not started clinical
Oh, you
trials.
haven't started?
Yeah, that's one of those big milestones.
And where's, how much is, that budgeted, the cost, and where do you have that?
Sure, actually I have a slide coming right on to that. So again, our first step here is going to be getting FDA approval. So our device is a combination device composed of multiple technologies that you see here. These are already FDA approved, they're on the market today for other uses. All we have to do is prove that they pose no greater risk to the patient than they do on their own in combination. This is called a 510K de novo pathway, and it's one of the easiest ways to get FDA approval. Then we'll start to work with Centers for Medicare and Medicaid Services in order to achieve insurance reimbursement. Unfortunately, there's an existing CPT code for lymphatic imaging, and this is where the revenue generation aspect comes into play.
Then, so you're gonna do, final 510K,
Mhm.
and then, so how many patients?
Yep, I got it.
So you do all of that?
Yep. Right here, so yep, we'll move past that. First step is a clinical trial to prove safety of the device for use in the clinic. And here we're just proving again that the combination of all those technologies, since they're already FDA approved, poses no greater risk to the patient in combination. Next trial is a clinical trial to prove safety of use of the device at home. And here we're just proving that using the device at home poses no greater risk than using the device in the clinic. And the final clinical trial is to prove efficacy, and this is really to get us insurance reimbursement status. And here we just need to prove that we're more efficacious than the current gold standard, which is a tape measure. So you can see we're getting through, our regulatory barriers in only 2 years and less than $1.3 million. Yeah, we've talked with a few experts related to FDA clinical trials, and we've actually doubled their estimates in patients and money. Because we're such less risky than most full clinical trials, we're doing 510K de novo, we're non-invasive. This is, in our opinions, a pretty right-on estimate.
Can you predict individuals that are susceptible to this disease? And how, if you can, how can you link that to the home marketing strategy? Because if she's unwilling to, on a preventive basis, using the sleeves, why would she be so willing on a preventive basis to spend the money to do this at home?
Mhm. Yeah. So unfortunately, no, we really can't predict who's more at risk than others. There's actually a lot of active research in this area right now. But really, we're looking at the American Cancer Society recommendation. This was just released, and the physicians are really now hammering home this to their patients, that within at least that 5-year window, this is a big survivorship issue that you should really heed. So we built into our model about a 60% adoption rate among patients based on our surveys thus far.
And for our clinical trials, we already have relationships with Cancer Treatment Centers of America and the Winship Cancer Institute at Emory that are willing to host our clinical trials. They want our device in their clinics.
And just how many devices are you going to produce for the clinical and reach these big phases?
So I think one of the things that, based on the number of sites and based on the number of patients, we'll at least have one device per site to monitor all of those patients. And so that's what we'll need to
And
manufacture.
then what about at home? The 120 patients? Is that-
Yeah, so we'll have a separate device for each of those 120 patients.
And do you have that built in, in the cost here, the budget?
Yeah, so in that budget, that's included the manufacturing cost.
So when would you actually make those?
When would we actually make those? So we would make that before the clinical studies actually started. And so the cost of the device to actually make is only about $150, so it's fairly cheap. And that's including manufacturing.
You don't have any cost in 2015 or 16 at all, manufacturing cost?
Yeah, so we've just lumped that into, if you see the research and development budget, so that actually covers the clinical cost. So that's why it's lumped in there. We didn't want to have too many line items.
If you've got Cancer Centers of America and a couple of others that are already showing some interest in doing clinical trials, because I think that, have they also given you kind of an estimate of what they might take, the number of devices?
Yeah, absolutely. So that's going to come right up into our sales strategy.
Yep. So once we get through our
Waiting for you.
Yeah, we're ready to tell.
I want to let you guys know, once we get through our clinical trials, we'll leverage the success through a group of key opinion leaders at speaking events, and that's going to help us generate demand. And so then we'll focus on our sales strategy. And what's unique about our sales strategy is we're focusing on 68 comprehensive cancer centers. And they're called integrated delivery networks, and it's the result of the consolidation that's been occurring in the healthcare industry in the past few years. So physician offices and clinics are absorbed to form larger networks and health systems. A patient can go to a single network and receive any care they might need for the rest of their lives. And this is important because the majority of our patients, 71%, is served at one of these 68 centers. So we can make a single sale to an IDN, such as the Knight Cancer Institute here in Portland. They would roll our device out to all of their physician offices and clinics that treat breast cancer patients. And this would provide us potential sales to multiple clinical uses, but more importantly, access to 2,600 patients for sales of our home use device. This is an extremely efficient efficient sales process.
Who sells into those same centers at this particular point in time? Can you piggyback on that sales
Sure.
process?
Yeah, and that's going to be part of P&C Healthcare, independent sales reps that have relationships with decision makers at those hospitals.
So if I can get access to the diagnostic device through my center, why would I spend money to have one at home?
As Mike was mentioning, because there's such a small window, you need to catch the disease as soon as it's initiated, and that small window occurs at any point throughout their lifetime, so they need to do it at home on a monthly basis, and this is really reducing your touch points in the healthcare system. And we think that the price point is pretty affordable, and with insurance reimbursement, it's projected up to 80%, so it should be pretty affordable for patients.
How often do the patients actually go back to, to the doctor?
Yeah. So
I mean, just for.
yeah, in the first year they go back every 3 months. Then it scales to every 6 months, every year, and then beyond 5 years, it's much less frequent than that. So if we just relied on the oncology follow-up visits, that's not frequent enough. And actually, every clinician we've spoken to that says, if you're going to roll out a product like this, it's going to live or die on your ability to get it into the home. So that's really been our primary focus, actually. Even the clinicians say you have to get it into the home for
It
this.
seems like there's a large enough population, that it could be an alternate distribution, channel is to actually set it up, in these clinics, in Walgreens and
Yeah,
Walmart.
yeah.
And,
We've looked into like a Quest Diagnostics type of model. Really, kind of just from our analysis, we think this is the way to go, but we're going to keep evaluating that for sure. It's a great idea.
And so we already have strong relationships with, as I mentioned, physician champions at Winship Cancer Institute at Emory, and also at Stanford Cancer Institute, including Stan Roxon, who is the world's leading physician for lymphedema treatment. And these doctors have told us that if we can prove our success in clinical trials, they would purchase our device.
Let me ask one more, just confirm. So the total size of this market from your estimates are 425 million, and that assumes what? What are you assuming the in-home sale for
Yeah.
what percentage of the patients? That's
Yeah, so that's total market, so that'd be 100% of the patients.
okay.
Yeah, for breast cancer.
Okay.
And then you can expand to other types of cancer. There's other ways you can get lymphedema. So the total market for lymphedema is actually even much larger than that, especially when you go worldwide.
And just so we're on that subject, do you have plans, to go outside the U.S. and also, your patent strategies, are you planning to cover?
Yeah, Rob, I can definitely talk
Yeah,
about that.
that's definitely something that we've considered, is filing the PCT applications as soon as possible. We already have the provisionals filed here in the US. We're going to follow those up with really broad PCT applications, which we're going to tailor as we further develop the business. This isn't a patent that we're building a business around. This is a business that we're going to protect through patents. So we're looking at all sorts of possibilities. That's why we're also employing a trade secret, because of the uncertainty right now in the software patent space.
We're really targeting internationally, probably Western Europe and Japan. That would be our two next kind of entry areas. Really a bit off in the distance at this point, but just kind of keeping the eyes forward. That's what we have.
So in order to determine the value of our company and our funding needs, we forecasted balance sheet, cash flow, and income statements. Oh, sorry. Thanks. And so we identified that we'll have an initial burn rate of $1 million, in the first 2 years. After year 4, we'll actually break even after selling only 8,500 diagnostics and ancillary products and services. In year 5, we'll achieve 35% operating margins, and this is higher than the industry average for medical startups. We've initially valued our company at $4.5 million, and we're willing to sell 45% equity in our company for this $2 million capital injection that would be tranched over 2 years. We will be using this money to complete FDA trials, secure our insurance reimbursement, finalize our prototype, and finalize our patent. At the end of year 2, we'll need another capital injection of about $3 million. But because we burnt out the technological risk in the first 2 years, our valuation will increase to about $9 million. And based on this, we'll be able to sell another 30% equity in our company. We're also exploring other non-dilutive funding sources, as well as other types of financing, such as convertible notes. We're going to use this money to ramp up manufacturing, increase our sales and marketing, host our private cloud solution, as well as finance our working capital. In those 3 years, we hope to establish relationships with 8 IDNs, as well as sell 15,000 diagnostics, increase our gross margins through scaling and getting volume discounts, as well as provide white papers that show the efficacy of a lifetime or long-term efficacy studies.
What do you mean by finalized patents?
So that's when we actually get the patent accepted through the patent office in the
So it
U.S.
was filed in 2000?
No, he really needs to finalize our full patent strategy. So we're in the process right now of we filed a provisional, so we're going to be prosecuting the patents. We're working with Troutman Sanders, it's a firm, global firm, local office in Atlanta. We're going to be working closely with them to make sure that the claims really do cover what we have, and that's why we want to take the necessary time to get that done.
So we've initially valued our company at $4.5 million, and this is based on a comparable companies analysis of other medical diagnostic companies raising Series A funding for FDA trials. We have also corroborated this valuation with a decision tree analysis and a discounted cash flow analysis, where we use a 60% discount factor. This really proves that our business model is in line with the market. We've also had discussions with venture capitalists as well as private equity managers in Atlanta. And based on our risk profile, as well as our easy 510K de novo pathway, they feel that this is a fair valuation. We wanted to provide investors with several exit opportunities because there are inherent risks.
In terms of your valuation, so your first one, you had 4.5.
Mhm.
Like you had in the previous slide, as well as your plan, it's post-money, is that?
Right, that's correct.
2.5, 3.
Right, 2 million, yeah.
4.5, and then the 9 was also, so 6. And
Right, 3.
3.
Mhm.
Right, and how did you determine the values, at that point in time?
So that was so the initial $4.5 million was based on all 3 evaluation methods, and then to do the valuation for the second round, it was actually using a discounted cash flow analysis as well as corroborating that with a decision tree analysis. Yes.
So do you have investors now?
We do not have investors at this point.
Okay, so there's no one in this to be.
Right.
Are you set, are you ready with terms and conditions and all that sort of stuff with your round, or are you still getting it?
We're still getting that together. That's correct. But we've been in close contact with both venture capital firms as well as private equity managers, and they're going to help us with that process. We also have business advisors. Well, this is because we're a university and they're helping our program out, and so they're also alums of Georgia Tech. So it's not because we're going to be asking them for money. Yeah, fair enough. We also have business advisors, that's what I'll get to. So we believe our best exit opportunity would be in 2020, and this is after we established business demand and proven our business model. Based on our research, companies such as GE Healthcare, Samsung Electronics, and Fujifilm have acquired companies similar to ours. For example, in 2010, Hologic actually purchased a medical device company that was using MRI to diagnose breast cancer. They used a 5.7 revenue multiple and acquired the company for $85 million. If we're not able to exit the business at this point, we feel that we're going to file an IPO in 2024. And these are 3 examples of medical diagnostic companies that have successfully filed an IPO last year. So we're a multidisciplinary team of graduate students from Emory Law and Georgia Tech. Nate and myself are MBAs, and we have over 11 years of financial services and healthcare experience. Robert and Jeff are both law students, and they're focusing on contractual and patent law, and they've been invaluable in determining our freedom to operate. And Mike Weiler, our PhD, has over 4 years of conducting lymphedema research. His research is the foundation of our technology. He also has access through his laboratory through any breakthroughs in this field. As we previously mentioned, we've all personally know people who've developed lymphedema, and we're all passionate about improving the standard of care of these patients. We've also been working with business advisors and scientific advisors to help us through the commercialization process. We've been working with Dr. Bob McNally and Bill Todd in Atlanta, and they have taken medical startups all the way to successful IPO exits. We've also been working with Dr. Amelia Zelnick and with Dr. Brandon Dixon, and they've helped us refine our technology and navigate the regulatory environment. Currently, Mike Weiler is our acting CEO, but we're also seeking to hire a new CEO who has medical startup experience. She will be responsible for raising Series A and Series B funding and refining our going-to-market strategy. We will also be working with contract service providers, contract manufacturers, and contract sales force. This will keep our company lean and provide us additional flexibility in the future. And as I've already mentioned, we've had initial discussions with all 3 of these different types of organizations. And for instance, we've talked to Billy Allen at Georgia State University, and he said he's willing to manage our clinical trials at a reduced cost because we're university students. We feel with this management team and these complementary assets, we're going to be able to successfully commercialize this technology.
So in addition to the expertise of our team, our affiliation with Georgia Tech and Emory provides us access to valuable resources to help further develop the business and the technology. The technology is actually from Georgia Tech. The lab has over 20 years of experience in lymphatic research and was actually recently awarded a $2 million grant from the National Institutes of Health. We're also supported by multiple lymphedema advocacy and awareness groups, and they champion our cause and they want our device in their clinics today. So we want you to remember the importance of life after breast cancer. Lymphedema has been a long overlooked problem for these patients, and the time is right. This community desperately needs a solution, and we have the technology to help solve this problem and the connections to get it through the commercialization process and into the hands of physicians to help transform the lives of lymphedema patients. We are LymphaTech, and we are improving the lives of breast cancer survivors.
Question on funding, given the need, and I think you've done a pretty good job of convincing us that there's room, is there an opportunity to get grants?
Absolutely.
Some of the nonprofits in this field?
We're actively pursuing that. There's Georgia Research Alliance grants, Coulter Foundation grants, all of which we've begun the process of applying for. Yeah.
I'm still thinking about the distribution model. And Bobby's point about the Walgreens of the world, and there are super reps, that are into national distribution with some of these big box chains, and with medical the way it's going, a lot of it is going into that sort of distribution. Well, that seems like a natural for you guys.
And we've definitely considered that, but I think in the beginning, our focus, we have to change physician behavior, so we really have to get it into the offices. We have to make sure that they understand the need. But long term, I think going distribution rights with the Quest Diagnostics is exactly something we want to look at.
Yeah, when you think long term in this world, Big Bang disruption, long term is 2 years from now.
Yeah, you're right.
It might be an interesting thing to build into your 5-year model, having year 3 a different curve on the life cycle. You might find that when you do your discounted cash flow, it might even look better.
That's great.
Yeah.
Any more questions? Judges? Good? Time.
If we can.
Thank you.